Hi, y'all. Welcome to the episode of McDoodles for Your Noodle on Pancoast Syndrome. So, Pancoast Syndrome is not a specific type of cancer, it's rather defined by its unique anatomical location.
Do you see the superior sulcus of the lung?
Anyway, who said that? So, the location is the superior sulcus of the lung or the apical part of the lung. So, we got this pancake here to remember Pancoast Syndrome, and he's an Australian pancake, which will make sense later. And he is a superior guy. He thinks he's better than everybody else. And when people don't pay attention to him, he sulks. So, superior sulcus of the lung. The tumor's danger comes from its tendency to invade these areas where the brachial plexus and sympathetic nerves are. So, here's a little rundown of the anatomy so you can picture it. The majority of Pancoast syndrome tumors are non small cell lung cancers. Historically, squamous cell carcinomas were the most common. And to remind you, quick rundown of what squamous cell cancer is like. It's in a central location. It's got keratin and intracellular bridges. More recently, adenocarcinomas predominate. Small cell is a rare cause of Pancoast syndrome. It's up to 5% of all cases. So, some more on adenocarcinomas. We know they're usually peripheral. There's glandular differentiation, and specifically with Pancoast syndrome, we tend not to see cough and dyspnea until late in the disease. So, based on the anatomy that we discussed earlier, and the fact that there is cough and dyspnea less common in the beginning of the disease, the most common initial symptom that's present in up to 96% of patients is shoulder and arm pain. So we'll go into why this happens. Pain is produced by the tumor invading the brachial plexus, parietal pleura, endothoracic fascia, first and second ribs, or vertebral bodies. And the pain can progress and radiate up the head and neck or down the medial aspect of the scapula, axilla, anterior chest, or the ipsilateral arm, so the arm on the same side as the tumor, following the distribution of the ulnar nerve. All right, so here we've got our Australian pancake back, and this is the big connection here. So the way you can remember that it can affect the ulnar nerve is this Australian pancake being annoyed. So he's like, "Arnar, you darn," right? Like, "Oh no, you don't." And Arnar kind of sounds like ulnar. Another classic neurological sign caused by this tumor's involvement in the sympathetic chain that happens in 14 to 83% of patients is called Horner syndrome. And you can think of Horner syndrome as a classic triad of symptoms. Um, the Illuminati? No, the triad for Horner syndrome. So, the key three findings on the same side of the face are ptosis, or a drooping eyelid with narrowing of the palpebral fissure, miosis, which is a decreased or constricted pupil size, and anhidrosis, which is decreased sweating. You can kind of remember that the eye is involved here with the eye in the middle of the pyramid. And earlier in the disease, before we get to the decreased sweating, you can see ipsilateral facial flushing, and increased sweating may actually occur. And then another thing that we may see of upper extremity complications is extension of the tumor into C8 and T1 nerve roots in 8 to 22% of cases. And this can cause weakness and atrophy of the intrinsic muscles of the hand, or pain and paresthesia of the fourth and fifth digits and the medial aspect of the arm and forearm. And I'm going to bring back in our Australian pancake friend so you can remember that it can compress the C8 roots. He just realized that he's a pancake and he's like, "Wait, I don't want to get ate, mate," right? And then he's like, "Take another one." See, I lost it there a little bit, but so you can remember that it's C8 and T1. Ite, mate. And when these nerve roots are affected, You can see weakness and atrophy.
They ask you how you are, you just have to say that you're fine when you're not really fine.
Okay, so diagnosis and staging of these tumors. A definitive diagnosis needs to be obtained before beginning treatment, and the way to do that is a biopsy via percutaneous needle biopsy under CT guidance. And these tumors are staged using the same TNM system as other NSCLCs. And due to the extent of local invasion, they're typically classified as T3 or T4 lesions. In the absence of distant metastases, they usually fall into stage 2B, 3A, or 3B. And you can see that the 5-year survival rate is between 64 and 85%. And because management will change if there is metastases, it's important for a thorough search of spread to mediastinal lymph nodes or distant sites using CT and PET scans. So moving on to treatment and management. The management of Pancoast tumors is complex and often differs from other non-small cell lung cancers. So for resectable disease, again, things come in threes, like the Horner syndrome. So we've got a 3-prong approach. So for resectable disease, you would think it's resectable, we're going to go right into surgery. But unlike other early stage lung cancers, for Pancoast tumors, concurrent chemoradiotherapy is the recommended initial step. And then surgery occurs 3 to 5 weeks after the completion of the chemoradiotherapy. Depending on how large the tumor is and what it's pressing against, it may require removing of parts of the sympathetic chain, brachial plexus, subclavian artery, or vertebrae. And then finally, after surgery, patients are going to typically receive 2 additional rounds of chemotherapy. And then, depending on molecular testing results, there might be a targeted therapy or immunotherapy. For unresectable disease, the recommended treatment is that chemoradiotherapy, followed by immunotherapy. The presence of Horner syndrome, tumor extension into the vertebral bodies or great vessels, and involvement of the lymph nodes are all associated with a worse prognosis. Whereas a good performance status, so that is being able to perform your daily tasks, minimal weight loss, and achieving a complete response after the chemoradiotherapy are correlated with a better survival. And these are my sources. Thanks for watching, and I hope this helps. Have a good day, mate.